In 1999, a 14-year-old girl of Turkish origin presented with vertigo and generalized tonic-clonic seizure. Magnetic resonance imaging (MRI) analysis showed multiple hyperintense lesions in T2 weighted images by hemispheric paraventricular white matter, frontal cortex, left insular cortex, and left brainstem. A symptomatic treatment with valproate was initiated in 2002, 3 years after onset of central nervous system inflammation. Mild thrombocytopenia, 110 times 10 to the 3 cells per microliter, occurred for the first time, but no further diagnostics were carried out. In the next year, she experienced various neurological symptoms such as hypoesthesia, weakness of her right arm, vertigo, and double vision. These relapses occurred in frequency of 1 to 6 events per year. MRI analysis showed a slow progression of inflammatory gadolinium-enhancing lesions, mostly localized in subcortical and paraventricular areas. Conventional angiographies revealed no signs of vessel stenosis and sinus thrombosis, or other signs indicating of primary CNS vasculitis. Under the assumption of relapsing, readmitting multiple sclerosis, these clinical symptoms as well as future relapses were treated with intravenous steroids until 2011. After our patient's first presentation to the clinic in 2011, an intensive clinical reevaluation was performed due to increasing doubts concerning the initial diagnosis of multiple sclerosis. Analysis of cerebrospinal fluid showed lymphocytic paleocytosis, intrathecal synthesis of IgG and IgM, impairment of blood-brain barrier integrity, and positive oligoclonal bands. A differential diagnostic, including serological, microbiological, and virological analysis from both her blood and CSF, revealed no sign for a symptomatic vasculitis, infection, or any underlying specific autoimmune disease. After another relapse presenting with unsystematic vertigo, we ultimately clarified the nature of her inflammatory leukoencephalopathy by performing a brain biopsy. This showed severe perivascular inflammatory infiltrates, as well as diffuse cellular infiltration within the parenchyma. The infiltrates were dominated by small, mature CD3 T cells and high numbers of CD138 plasma cells, whereas only low beta B cell numbers could be observed. A diagnosis of Evans syndrome is a rare hematological disease commonly defined by the combination of simultaneous and sequential autoimmune hemolytic anemia and immune thrombocytopenia, sometimes associated with the neutropenia, in the absence of known underlying etiology based on the detection of CD20 beta cells and CD138 plasma cells, both by flow cytometry. assessments of her cerebral spinal fluid and by immunohistochemical stainings. We initiated treatment with anti-CD20 monoclonal antibody rituximab. This treatment regimen could be beneficially used in CNS inflammation and has already been reported to be effective in cases of ES, prognosis Evans syndrome.